morning, everyone. Great to see all of you. My name is Phyllis Tien, and I am from the UCSF-Bay area, CFAR, and I am also the co-chair of our Inter-CFAR collaboration on HIV research in women, and my co-chair here is...
Sure. Good morning, everyone. I'm Renee Heffron from the CFAR at the University of Alabama at Birmingham. It's really a pleasure to be here, and it's so great to be back in person and have so many of you here today. Okay.
So we're really excited to welcome you to our 9th Women and HIV Symposium, and it is the first one that is in person since 2019. So our theme for this year's symposium is Women and HIV Across the Lifespan. So, we'll talk a little bit more about the agenda and, the fantastic speakers and program, but we've got a few announcements first.
So first of all, we really want to thank the funders of this conference. There's a conference grant that's supported by NICHD, NIDDK, and NIAID, the institutes within the National Institutes of Health, and really happy to have program officers, senior program officers from those institutes here with us. And then we also really want to thank the UCSF-Bay area CFAR for putting this together and really supporting from their prime grant to put on the conference. And then a number of other CFARs also have contributed in travel scholarships and in many, many ways to bring us together. This conference is really truly a great exemplification of what the CFARs can do when they come together and support this kind of activity. So thank you so much to our funders.
So, in terms of our agenda, in an effort to save paper, you can go to this link, or you could use the QR code below to see all the details of our speakers, our oral abstract speakers, and the speaker bios and full abstracts. So, please take a look at that. And I will now go on to talk a little bit about a few of the housekeeping issues. Really important, the bathrooms, the gendered bathrooms are to the left out of the door and down the hall. The gender-inclusive bathrooms are upstairs on the second floor in room 275 A and B. There's also a water fountain out this door and to the left. I know a few people have asked me about water fountains. We'll also try to bring bottled water and so on out to the back. The second thing is, I do want to welcome our NIHPOs. Again, they've been fantastic in terms of funding, some of the program today, and also many of our investigators here. Can our NIHPOs stand and then maybe give their names and institutes?
Hi, Elizabeth Barr at the Office of Research on Women's Health.
Hi, I'm Denise Russo, NICHD.
Peter Perrin, National Institute of Diabetes and Digestive and Kidney Diseases.
I'm Quan Nguyen, and I'm also at NIDDK.
Gretchen Buckler at NICHD.
Sakai Chidea at NCCIH, National Center for Complementary Integrative Health.
Great, thank you so much. So, in terms of lunch for today and tomorrow, actually for tomorrow, we will have a session where people can meet our NIHPOs. So just to let you know. So in terms of today, can we just ask that people with dietary restrictions please get up first to make sure that they can get their lunches first. And then the other thing I wanted to say about our lunch sessions today. So for today, there's going to be scientific breakout sessions. And the tables are numbered, and each number is associated with a theme. So you can look at where you're assigned to, and this is based on what you had indicated on your registration form. So the top number is the table number to go to for lunch today, and then the bottom number on the back of your name tag is for tomorrow. And there's just a reminder of the conference code of conduct. So, please report any violations to Lauren Sterling, have her email address here and her phone number, myself or Renee. Our email addresses are here. Some miscellaneous things. We do have surgical masks at the registration table, outside, if anyone needs any. And then please, if anyone has any cold-like symptoms or develops cold-like symptoms over the next 2 days, please wear your mask. There are a couple other things, and that is to, when you have questions during our sessions today, please make sure to speak in the mic. We'll have a roving mic, so we'll get it to you. So, maybe raise your hands when you have a question. We're also recording the symposium over the next 2 days, so just to let you know about that. Okay, thanks.
Great. So if I'll just give you a real quick tour of the agenda. For the next 2 days, we have 4 sessions. And for each of the sessions, we have some invited plenary talks, and then we have oral abstract presentations. And Phyllis already talked about the lunches today and tomorrow. Tonight, or this afternoon before we break for the day, is our poster session and a networking mixer that's hosted by the early career faculty at UCSF and the CFAR. And so that's sort of how the agenda's been laid out. The first theme is on reproductive health and HIV. Our next theme, session 2, is antiretroviral therapy and metabolism in the era of INSTIs, with a focus on sex and gender differences. Tomorrow, we'll talk about aging with HIV across the gender spectrum, and then we will finish by talking about, hearing about NIH research priorities for research on HIV in women.
Just one other thing about people who do have posters, our abstract presenters, please put them up around at the break time. So that's going to be around 10 o'clock. So 10 to 10:15, please put up the posters that you have. And I think we've circulated around the tables the numbers that your poster is assigned to. So you'll see the numbered boards here. Great.
So let's start our first session. I'd like to invite our speakers for the first session to come up to the table. And I'm just going to turn it over to Lauren Suchman from UCSF and also Dominika Steedman from UCSF, who will be leading the session.
Good morning, everyone, and welcome to San Francisco. We are so glad to see you all here. We are going to start out this conference with a bang on a topic that has been described as, I pulled these from some commentaries, on the frontiers of HIV stigma and moral panic, a key reproductive justice issue, among many other provocative statements. The topic of breast and chest feeding in the setting of HIV has been controversial for a long time, and I really wanted to appreciate the advocates and patients who pushed this issue and took charge of our research agenda and our patient care to bring it to the fore and recognize that, quite frankly, we did a really bad job caring and counseling for patients for a really long time. And it was time to listen to patients and advocates to change our ways. So I wanted to first of all, just start by appreciating the conference organizers by by focusing on this topic, and we are really lucky to have fantastic experts up here today to share where we're at now and where we're going. So to start, I wanted to present my friend and colleague, Dr. Judy Levison. Judy is a professor in the Department of Obstetrics and Gynecology at Baylor. For 20 years, she led the Harris Health System Women's Program, which provides obstetric and gynecology care to women living with HIV in Houston. She also sits on the Perinatal Guidelines and provides consultation to the National Perinatal Hotline. Of note, Judy was one of the clinicians at the forefront addressing this topic head-on, thinking through in papers and abstracts and conferences how we can do better. So we couldn't be more privileged than to hear from Judy today on this topic. Thanks, Judy.
Great, thank you, Nika. I'm glad this is being recorded. If I'm feeling bad one day, I'm going to just replay it.
All true.
I'm really honored and excited to share with you some of the changes related to infant feeding and people with HIV. So I'll be giving you the obstetric perspective, and which will then be complemented by Liz Lowenthal speaking about the pediatric perspective, and then we'll have a patient perspective. I have no disclosures, and I hope by the end you'll be able to describe the motivations of those who want to breast or chest feed, state what's known about the risk of HIV transmission via breast milk with and without antiretrovirals, and explain what's changed in the US Perinatal HIV Guidelines as of 2023. And just a note, I may use breastfeeding, chest feeding interchangeably, and when I say breastfeeding, please also hear chest feeding. But be aware that research done in the past on this topic has investigated cisgender women, so results are reported as women. So just very briefly, some history. Once upon a time, prior to antiretroviral therapy, the risk of perinatal transmission was 25%. And in this particular slide, I'm referring to mother-to-child transmission during pregnancy and delivery, and not including breastfeeding. And then someone got very brave in the 1990s and dared to give AZT to pregnant women, and found that just with AZT alone prior to during pregnancy and during labor and delivery, and then for the infant after delivery, the transmission dropped from 25% to 8%, so a 60% drop. With ART, less than 1%, and now we have evidence that if someone is on ART prior to pregnancy with an undetectable viral load throughout pregnancy and at delivery, among 5,500 mother-baby pairs, there were no transmissions. So this is really how I got into this, and it was my patients who opened my eyes that infant feeding was an issue. And this is a composite of many of my patients, and I think some of you will be able to identify with this. And I'll just also make a note, the artwork that you see on the right was done by a middle schooler in Houston. There's an art project every year where middle schoolers and some high schoolers in art class are assigned to do a piece of art related to HIV/AIDS. And it then is entered into a contest, and you'll see a little bit more of this later. So 32-year-old woman, originally from Nigeria, was diagnosed with HIV during her current pregnancy. And during prenatal care, she communicated to her obstetrician her desire to breastfeed. She feared that not breastfeeding would raise suspicion in her community about her HIV status. She'd also heard and read so much about breast is best, and both for her baby and for her own health. She was referred to the local pediatric HIV specialist who reviewed the risks of HIV transmission via breastfeeding, and the patient expressed great relief to discuss her concerns with a provider. Knowing she had options provided a space for her to contemplate the best decision for her situation. She opted to breastfeed for 3 months, both to prove to her community that she did not have HIV, and in response to public messages that breast is best. She remained virally suppressed on antiretrovirals while she breastfed. Her baby was given daily nevirapine prophylaxis while breastfeeding, and her baby remained HIV negative. And, you know, once upon a time, I just said, oh, you know, we recommend, you know, formula, no breastfeeding. And then I had patients who said, you know, that's a problem. And I learned to say, oh, we recommend formula. Is that a problem for you? And the tears would start rolling down faces. And so that was really what opened the door to make me realize that our policies were not quite matching our patients' experiences. So this was just one common example, but there are women of many other racial and ethnic groups who are expressing a desire to breast or chest feed. So what is the risk of transmission via breastfeeding? So prior to the availability of antiretroviral therapy or infant antiretroviral prophylaxis, the risk of an infant acquiring HIV through breastfeeding was about 15 to 20% over 2 years. And that's just too high. But achieving and maintaining viral suppression through ART during pregnancy and postpartum decreases breastfeeding transmission risk to less than 1%. But at this point, we still have to say, but not zero. But among those studies, not all had maternal viral loads consistently available, which makes it a little different from the US. And one of the largest studies and most recent ones is what's known as the PROMISE study. And they randomized mother-baby pairs to either the mother getting antiretrovirals or the infant getting prophylactic nevirapine while breastfeeding. The results from the two groups were very similar and basically showed a 0.3% and 0.6% transmission at 6 and 12 months. So that's 3 per 1,000 and 6 per 1,000 at 6 and 12 months. But I want you to see two of the cases that contributed to that 0.3 and 0.6% transmission and keep this in mind because it plays into some of our criteria for who are good candidates for breastfeeding. So here, what you see is on the left, there's one case where what you see on the top is you see the little black asterisks, and that's the point at which the baby was diagnosed with HIV. On the very bottom line, you see the mother's viral load, and 0.0 is delivery. So she did not have an undetectable viral load prior to delivery. She did not have an undetectable viral load 4 weeks after delivery. It was only at her 12-week check that they finally had an undetectable viral load. And at 14 weeks, her baby was diagnosed with HIV. The case on the right, baby was diagnosed later, as you can see by the black asterisks on the top. But look at the mother's viral load, the bottom line, and there at delivery, the mother had a significant viral load and also did not become undetectable till 14 weeks, and her baby was diagnosed many months postpartum. But as you'll see, these would not be our ideal candidates, and so if you perhaps limit or who is breastfeeding in relation to viral load, could we get closer to zero? So just to walk you through the guidelines and just how far we've come, and I think Nika just gave my talk in saying how I think we were misguided in the beginning. So 1985, it wasn't even called HIV at the time. Women with this new unusual infection should be advised against breastfeeding to avoid postnatal transmission to a child who may not yet be infected. Sounds very dire. 2015, so that's just 7 years ago, was the first time where some of us in the trenches said to people on the panel, it's fine to say don't breastfeed, but that's just not the experience we're having with real people. And so we were allowed the following sentence. in discussing the avoidance of breastfeeding as the strong standard recommendation for HIV-infected, and I cringe with the language being used, women in the United States, the panel notes that women may face social, familial, and personal pressures to breastfeed despite this recommendation, and that it's important to begin addressing possible barriers to formula feeding during the antenatal period. So this was a major leap forward. And then 2018, finally, was the first section in the perinatal guidelines and a much greater recognition that there were going to be some women breastfeeding. But again, as I cringe at this language, breastfeeding is not recommended, bold and underlined. It's probably the only bold and underlined statement in the entire guidelines. For women living with HIV in the United States, women who have questions should receive patient-centered care. And when women with HIV choose to breastfeed, despite intensive counseling, they should be counseled to use harm reduction measures to minimize the risk of HIV and transmission to their infants. So at the time, we thought this was a great leap forward, but in retrospect, it's still cringeworthy. So 2023, what was different, and don't worry about the fine print, I just want you to see the amount of yellow. The yellow tells you these are new recommendations, and that's how we signify in the guidelines when they're first put out, that if you are familiar with the guidelines, look at the yellow because you'll see what's new. So quite a bit changed. So the major change was that now we're saying support parental choice through shared decision-making, not a specific infant feeding mode. And one of the things that was different was there were some new considerations, and one was the health benefits of breastfeeding. So for the infant, decreased risk of developing asthma, obesity, type 1 diabetes, respiratory disease, otitis media, SIDS, GI infections, and necrotizing enterocolitis. For the mother, decreased risk of hypertension, type 2 diabetes, breast and ovarian cancers. There were equity considerations. Black women are disproportionately affected by HIV, and people of color experience a greater burden of many health conditions that may be alleviated by breastfeeding, like hypertension and type 2 diabetes and such. And there were the cultural considerations that there are environmental, social, familial, and personal pressures to consider breastfeeding, and the fear that not breastfeeding would lead to disclosure of HIV status. And I can't emphasize the last one enough, because in Houston we have a large Nigerian community, Ethiopian community, Cameroonian community, and if you are seen not breastfeeding, it is the equivalent of waving a red flag at your community, I have HIV. And you may think that the stigma in the US in general is high. It is much higher within those communities. And I had one woman tell me, I will need to move if I am not breastfeeding, because not only will I not get invited to anyone's home if they suspect I have HIV, but no one will let their child play with my child, even if my child does not have HIV. So it's a big deal. So what was different this time around was we integrated community input from members of the Well Project, the International Community of Women Living with HIV, North America, and others. We had input from lactation specialists from CDC. And it was we always were aware of what the pediatric panel making their national guidelines was doing, and they were aware of us, but we really hadn't communicated that much in the past. And this time there was very strong collaboration. They and we made our own guidelines and then swapped. And then everybody from pediatric gave input into perinatal and vice versa. And it was a lot more work, but well worth it. And I think we finally came out with something where we really had consensus, as opposed to either us cringing at what the pediatric people finally had published or them cringing at what we had published. And so it was really a new level of working together. And I think this is really important that you take this back to your people. CDC chose to refer any queries about infant feeding in the US to the perinatal guidelines. Before that, they had their own recommendations, which hadn't been updated in decades. And one community member said to me, my life's dream is to have CDC update their guidelines. And so we got one step better, and we now have one set of guidelines. And I hadn't realized what a big deal it was until she said this to me, and I realized, well, if there's something I don't know that much about that CDC might have input on, I'll go to the CDC website. So what are clinicians doing? Why should they know about the National Perinatal Guidelines? They know about CDC. And so this also really now unifies us. And recently someone told me that their WIC providers were still not on board with these new policies because CDC hadn't updated their guidelines. And I said, go tell them. Well, actually, I talked to HRSA and said, you've got to get to your WIC people because they are still going by old CDC guidelines. So again, in spreading the word, check. What are your providers, including like WIC, what are they doing and what are they saying? So these are just some of the faces behind the community, and these are members of the Well Project. If you're not familiar with the Well Project, during the break, Google them, and they're a wonderful advocacy organization for women with HIV. So just what's some of the wording in the guidelines? We still say, and I really do want, we're not saying, oh, yeah, you have HIV, go ahead and breastfeed. Far from it. For people with HIV who are not on ART and or do not have a suppressed viral load, replacement feeding with formula or banked pasteurized donor human milk is recommended to eliminate the risk of HIV transmission. But if you have an individual with HIV on ART with consistently suppressed viral load during pregnancy at a minimum during the 3rd trimester, and at the time of delivery, they should be counseled on the options of formula feeding, banked donor milk, or breastfeeding. And again, we emphasize to people, yes, formula, no risk. Right now, with fully suppressive ART, we're saying risk is less than 1%, but not 0. And I think one other controversial issue, and I want you to think about this as you go forth in creating protocols and proposals for research. Mixed feeding has been another sort of controversial topic and where we don't have all the answers. If breastfeeding is chosen, exclusive breastfeeding up to 6 months of age is recommended over mixed feeding, and that would be, let's say, breast milk and formula. And that's just general breastfeeding pediatric recommendations for anybody. Acknowledging that there may be intermittent need to give formula if there's infant weight loss. The milk supply has not yet been established, and that's been a big sticking point in many hospitals. A mother not having enough stored milk, and solid should be introduced as recommended at 6 months of age, but not before. And the reason this has been of concern is that in the late 90s, before antiretrovirals were available, and I emphasize before antiretrovirals were available, there were studies showing that when they compared mothers who formula-fed, exclusively breastfed, and mixed-fed, and in these studies, it turns out, we didn't realize this at first, it wasn't just formula, they also were sometimes giving solids like at 2 months of age. So that irritates the baby's gut and makes baby more prone to getting HIV. But there was exclusive breastfeeding that had a lower risk of transmission than mixed feeding. So that's sort of been sitting there for the last 20 years, but now we have ART. And so there are some people say, well, we just don't know now that we have ART, whether that holds at all. And other people are saying, this has nothing to do with 2023 because we have ART. And so depending where you fall on that spectrum, there's this like concern, and because even a few years ago in our hospital, one baby was given formula by accident by the nurses, and the PDID people said, oh, can't breastfeed, and they have changed their tune because we realize we really don't have evidence saying that occasional formula is a problem at all, but we need data, and that would really help. Situations to consider stopping or modifying breastfeeding if there's a detectable viral load, and we're very aware we did not specify a viral load because we don't know. Breastfeeding should be temporarily stopped. Options include giving previously stored breast milk, pumping and flash heating, providing replacement feeding, or cessation of breastfeeding, completely repeating the viral load and reassessing continuing breastfeeding. And if the repeat viral load is detectable, that's where the panel says you should stop breastfeeding. But again, what level? I certainly know of one mother who would putter around at viral load of 30, viral load of 60, viral load of 45, and she was going to breastfeed no matter what, and, nothing bad happened. But I think we just, again, what level should we be saying is where you really should stop. Again, think about it for your research. I'm going to leave this to Liz, but just that there is no consensus about antiretroviral prophylaxis for infants, and that depending on what institution you're at, it is all over the map. One other is, and I hadn't realized how important this would be to clinicians, engaging child protective services or similar agencies is not an appropriate response to the infant feeding choices of an individual with HIV. You may have other reasons to call child protective services, but the mode of infant feeding should not be it. And many people have reported that after expressing their interest or intention to breastfeed, their providers threatened to report them, or did report them, to child protective services and separated mother and baby. And such engagements can be extremely harmful to families, can exacerbate the stigma and discrimination experienced among people with HIV, and are disproportionately applied to minoritized individuals, including Black, Indigenous, and other people of color. And just to show the interest that has been going on in the US over infant feeding, this is a record of calls to the perinatal hotline out of UCSF. In 2014, less than 5% of the perinatal calls had anything to do with infant feeding, and in 2022, over 25% were related to infant feeding. So people are paying attention, and we're now also seeing data accumulate on breastfeeding in high-resource countries, because that's one thing that many people, and it's controversial. How much can you rely on data from low-income countries? I think a lot. But are there some things that are different in the U.S. and Europe and Canada? Yes. So you see these sort of pitiful numbers, but 3 from Canada, and 10 from Baltimore, and 72 from Canada and the U.S. And but the numbers are growing, and people are recognizing this is something worth being aware of. And I think this is a wonderful study done by, at that time, pediatric residents at UCSF, where they did a survey of 100 clinicians about really their comfort level with having patients who wanted to breastfeed. And I think they summed it up really well with the nice seesaw you see on the lower left. And there's the respect for patients' informed choice and respect for patient autonomy. And then over on the right, there's the poor clinicians who are coping with, somebody gonna sue me? I'm too scared because what if your baby is the one that where there's transmission and I get blamed? Our hospital doesn't have a policy for this. We can't do this. And even a refusal to provide care. And so I think it really just encapsulated the discomfort that so many of us have dealt with. And patients similarly have struggled to navigate this, because when their clinicians were confused, or they knew their clinician was against it, but there was someone across town, like Liz, who they could go to and maybe get support. And these are just some of the questions that have come into the National Perinatal Hotline. And again, this is where I hand you a menu of things to think about working on, where we have definite implementation gaps. So who are the best candidates for breastfeeding? I mean, right now we're saying, okay, 3rd trimester, undetectable viral load going forward. What about this mixed feeding? It would be so nice to put that to rest, to say, look, this woman, gave formula this many times, this one gave it this many times, and at this point in baby's life. But we really haven't asked that a lot, because women knew they weren't supposed to, so they would say, no, oh no, I wouldn't do that. And when to consider stopping or modifying breastfeeding, what viral load really is dangerous and what isn't. What are the responsibilities of the care team members? And we've been talking about that every institution is now inventing their own wheel. And when I think really we could get together, and our Jenny McKinney, who's in the back, who's one of my partners in crime, we have a breastfeeding medicine doctor who she's been working with, and they've really been working on just education for the pediatricians, the nursing staff, the NICU, and explaining to them who are candidates and how to deal with certain problems. And then the antiretroviral prophylaxis issues that, again, Liz will address more. But we have, some babies getting 2 weeks of AZT and other babies being given full antiretroviral therapy, not prophylaxis therapy while breastfeeding. So we just don't know what is really maybe the best. This is just what the hotline does. They have many hotlines, and I'll have it on the last slide too, because get your phones out, because I don't want you to leave without having this phone number, which you'll see in a minute again. Just on a final note, some more artwork that I just thought that just spoke to me about stop the stigma, unity, prevention, education, no shaming, and never give up. You can always be heard. These are 12-year-olds. So going forth, the www.hivinfo.nih.gov is where you find the guidelines, and there will be a new set of guidelines that will be released end of January, early February, now in their almost final draft. And this is where I want you to put it in your phone, the 1-888-448-8765, and that is the perinatal hotline. That is 24/7, 360 days a year. You get a real human being. And there's no such thing as a stupid question. It's 3 in the morning, you have a newly diagnosed person with HIV in labor and delivery, and it's like, oh gosh, what did they tell me to do? You pick up the phone and you call. Similarly, even though I work with them, I sometimes call, and they say, Judy, what are you doing calling? It's like, I need another brain to bounce this off of. I know there's no single right answer. And usually, after a back and forth, I have this woman with this, and we come out with some ideas I wouldn't have thought of. And so I just cannot say enough about the service, and I wish that number were posted on every labor and delivery. Thanks. I don't know what to do.
Judy, thank you so much for that talk. We're going to save questions until the end and quickly switch to the pediatric perspective. Dr. Lowenthal is a pediatric HIV clinical specialist and epidemiologist who focuses on really how the care and treatment of adolescents and children in low-resource settings who are living with HIV. She is the PI of multiple R01s and has done a ton of research focused on this topic, and we are really lucky to hear from her today. She's also the research director of the Children's Hospital of Philadelphia Global Health Center and the director of the developmental core for the Penn Center for AIDS Research. My only disclosure is I failed as a moderator to keep us on time, so I'm going to give you 20 minutes, and then I'm going to politely say, please try to wrap up. I'm holding myself accountable.
All right, I'll try to be fast. Thank you. I have no conflicts of interest, and the objectives to build on what Judy said is, first of all, to describe some of the complexities of counseling and supporting people living with HIV who choose to breastfeed, and then present a little bit of a model of collaboration during the breastfeeding period. So the first place that we start when a woman comes in and is pregnant is to say, what are your infant feeding plans? And often they'll say, wait, I thought I had to formula feed. And other times they say, I absolutely want to formula feed because I want there to be zero risk to my infant. But often it's a big conversation. And the big points that we want to make sure they understand is that undetectable equals untransmissible may not fully apply. One of the points that we've evolved from a bit in Philadelphia is moving from giving women excuses to formula feed that could be socially acceptable to saying needing an excuse to not breastfeed shouldn't be your reason to not breastfeed. If you're really worried about transmission, that's one thing. If you're worried about appearances, that shouldn't be your reason, but we can give you a safer way to feed. The cultural importance, the benefits of breastfeeding, and distrust of formula are all things that I hear about when I ask about people's motivation. So 1% is not zero risk, but formula feeding has risks too. I had a family who wanted to breastfeed because they thought formula was poison. And they had all kinds of data on all the contaminants that had been found in formulas. And then we had the formula recall actually while this woman was breastfeeding. We also know that breastfeeding is good for the baby and it's good for the mom. It lessens risks of a number of different illnesses for both. So Judy showed this beautiful picture earlier, and she was talking about the mother. So what I hear a lot from my pediatric colleagues who are really still worried about allowing moms to breastfeed is, who is the patient? So if your patient is the child really never has informed choice. And so this is where that paternalism balance becomes really hard. Because if you really think as a provider that you will have to do what's in the best interest of the child who is your patient, things may be a little less balanced in certain cases. So there's my patient. And what does my patient want? Well, if they could tell us, I think they would say they want the best nutrition. They want the best immune support. They want the best possible bonding with their parent. They want their mother to be healthy, both physically and emotionally. And of course, also, they want to be HIV-free. So Judy talked about the PROMISE study where the risk of transmission was 0.3% in the first 6 months and 0.3% in the second 6 months. I want to call that out specifically because you have to mix feed in the second 6 months. So that does get a little bit at that question of how dangerous is mixed feeding, at least during that second 6 months of the first year of life. Here's a meta-analysis of a number of different studies. So adding on to the PROMISE study, you can see that across studies in the decade between 2005 and 2015, women on an ART with a variety of different suppression rates based on this study, there was about 1 in 100 who were infected by 6 months and about 4 in 100 by 12 months. So I'm going to go through 4 challenges, and I'm going to try to do it fairly quickly because I know I'm under a time crunch. But challenge number 1 is, how do you counsel around all of this uncertainty and nuance in the literature? So you have a mom who says, I want to breastfeed, but I don't want my baby to be that 1 in 100. Can we make it lower by giving my baby medicine too? And we've already said the answer to U equals U with breastfeeding is almost, not yes. So can we make the risk lower with infant nevirapine or with infant triple therapy? The answer is still maybe, because we don't have the data. Overall, we know that the transmission can be less than 1% across many studies. And I'd like to point out a study called HPTN 046 that I've heard in many settings be cited as indicating that infant nevirapine does not lower the risk. And this is where I put my epidemiologist hat on and say, wait a minute, it wasn't powered to answer that question. So in this study, there were 222 women on ART with infant nevirapine and 222 on ART without infant nevirapine. And there was 1 infant in each group who became infected. So in both groups, the rate of infection was 0.5%. Look at the confidence interval. the confidence interval was 0.01 to 1.4%. What that means is that the risk of mother-to-child transmission in each arm, if you were to repeat this lots and lots of times, would come up somewhere between 1 in 10,000 and 140 in 10,000. It's not the same number on both sides of that confidence interval. So this is the kind of game that I like to play with my students. How many mother-baby pairs would you need to show that the risk was halved by using nevirapine? Before you answer that, how many of you would give nevirapine if it halved the risk? Okay, so what do you think? A, B, C, D, just yell something out. How many mother-infant pairs would you need in this study that Judy's hoping someone's gonna fund? Okay, I hear everything from A to D, and the answer is D. Now, what about if it reduced the risk by 20%? I'd still want to give nevirapine. It's pretty low toxicity. It's easily tolerated. It's once a day. So that would take about 14,000 mother-infant pairs. So if anybody knows a funder who's willing to do that, please give me a call. Otherwise, we may never really get the data that we want to answer this question. So we do know that prophylaxis helps infants who are at increased risk. We know that if the mother gets no ART and the baby gets ART from the PROMISE study, that the risk is about the same. So obviously it's helping to give just nevirapine if the baby's at higher risk. There was also this study presented at the CROI conference this year. It's not yet published, but in Zambia and Burkina Faso, they were looking at the WHO guidelines, which make a lot of sense, but don't really tell you how to implement it, kind of similar to our guidelines. So they say if the mother is fully suppressed, the baby doesn't need nevirapine, but if the mother's not fully suppressed, the baby should get nevirapine. So how often do you think they monitor mothers? Not very often. So what this study did was it randomized women to standard of care monitoring, which was very little or no monitoring, or viral load testing at 68 weeks postpartum and 6 months postpartum. In the maternal enhanced monitoring group, 102 out of 753 mothers had a viral load greater than 1,000. So in that group, they gave infants prophylaxis, which in this case was lamivudine. In the standard of care group, 0 were offered prophylaxis. And within 12 months of follow-up, there was 1 HIV transmission in the intervention arm and 6 transmissions in the control arm. This is very preliminary data, but I think this is going to give us some important sense of what we're missing in implementation in a lot of settings. So as Judy said, our guidelines in the US have no consensus on ARV prophylaxis for the infant. And people are doing everything from no prophylaxis to triple therapy. At CHOP, we're recommending infant prophylaxis, and we use zidovudine for the first 4 to 6 weeks of life, and then daily nevirapine until 1 month after cessation of breastfeeding, with individual adaptations when issues come up where we think the risk may be higher. So, challenge number 2. Undetectable is harder to maintain postpartum. Judy kept saying, how do we choose the mom? Let me show you our data from Philly. This is old data, and we're working on updating this graph. But if you look at where we were in Philadelphia between 2005 and 2011, which was the last time that we had a chance to look at the maternal postpartum cascade, viral suppression among women who were in care for HIV during pregnancy was less than 1/3 1 year postpartum, and was less than 40% at 60 days after delivery. So in this context, how can I tell you who is the mom who is going to be in the 31%, and who is the mom who may be at a higher risk during breastfeeding of having viremia. So what do our guidelines say about monitoring moms during the postpartum period for breastfeeding women? I haven't seen what's coming out in January, but from the old guidelines, it's really nothing. It says talk with an expert, decide what you're gonna do, decide amongst yourselves. My opinion is more is probably better, and we're doing monthly monitoring for the first 6 months. And then if they're breastfeeding beyond 6 months, our numbers have been low, and we've talked to the woman about what she's comfortable with and what we're comfortable with based on how she's been doing. Challenge number 3, preparing for a successful start. I get a call from Bill Short, sitting in the back of the room there, who sees a lot of our pregnant women in Philadelphia, and he says, I have a mom who wants to breastfeed, please talk to her. So we start working together, and there's this sense sometimes that we can't talk to too many people because everyone has different opinions. I want to tell you, this is not that case. There's no too many cooks will spoil the broth here. We've got to work together. We've got to have teams who are communicating. We found a written feeding plan to be helpful, and we've also found that lactation support before delivery is essential, because we've had a number of women who wanted to breastfeed, and then the first couple of days of life, it just didn't work out because they didn't have the support they needed. So a couple of real-life examples. Mom, who I'll call A, made plans to breastfeed with her HIV provider and with her OB provider. They did extensive research. They switched her meds to the medicines that they felt they had the best data for during pregnancy and during breastfeeding. She had a breast pump, and she brought it to the hospital to help aid her in lactation. But there was a pitfall. Nobody talked to the pediatric team. So the pediatricians came in and they said, no, we will not let you use that breast pump. If you use that breast pump, if you indicate that you're breastfeeding, we will report you to Child Protective Services. So this woman went home not breastfeeding and then ended up in our clinic asking for help establishing breastfeeding later. I'm not going to read through this, but I'm happy to share if anybody wants it. We started off with a signature form that came from Judy's clinic, and we evolved it so that it's a little bit different now, but this is basically all the points that we go through in counseling that happens before the baby is born. So we want to make sure that the mom understands all these things, that the person who's going to follow the mom postpartum understands all these things, that the person who's following the baby understands all these things, and that there's a feeding plan where we all say, okay, we understand a lot of information, we understand U equals U, it does not apply, we understand what we can do to mitigate the risk, and we've agreed that we're going to work together. And this goes to the hospital. This goes in the mom's chart. And at the bottom it says, call me if you have questions. And then they call me and they say, can I put your name in the chart that you're taking responsibility? And I say, sure. And we go from there. So real life example, mom B, the feeding plan was determined with collaboration with the maternal team and the infant team. This was a mom who was giving birth in the suburbs. She wasn't in Philadelphia where we had relationships with the hospital team, but she had her checklist. She brought it to her doctors. She went to the delivery unit, she talked with them, and everything worked out. The mother, this was a really nervous mom. I said monthly viral load monitoring. She said, please check every 2 weeks. And for a while, she did every 2 weeks. And the nurse practitioner would call me every time the mom got a viral load, and eventually she started doing monthly. And I saw the baby every month after the mom had her viral load, and they did beautifully. until the mother developed low-level viremia. As per the guidelines, we immediately repeated it. I went from 1 drug for the infant to 3 drugs for the infant. And she continued breastfeeding. She again had low-level viremia, and we decided with 3 drug prophylaxis for the infant that we were all believing that we were doing something collaboratively that still made sense. And she weaned later, and the infant is now HIV-free. Another mom, this was before the guidelines changed, she said, "Why was I encouraged to breastfeed in Africa, and here I'm told it's bad?" So a feeding plan was determined for her in collaboration with the full team. I've actually combined these 2 cases in my head, so this was the every 2 weeks mom. The other one was actually monthly. This mom breastfed for almost 2 years, and her infant is weaned and HIV-free. So challenge number 4, my last challenge before you pull me off the stage. I've had people say, "Can I have that piece of paper so I can counsel this mom who's in labor and nobody's talked to her about breastfeeding?" And I say, it's not about that. It's not about one decision. There are lots of decisions that happen along the way. It's not just, do I start breastfeeding? It's how do I start? How do I maintain? How do I support the infant? How do I support the mom? What happens if mom gets mastitis or cracked nipples, which we know increases the risk? What happens if the infant gets thrush, which we think might increase the risk? What happens if mom or infant gets sick, if mom has viremia? When should I wean? How should I wean? All these things need a team approach. So the mixed feeding issue, I know I'm running short on time, so I'm not going to go through the data, which Judy already touched on, which is that in the pre-ART era, it was a huge risk to mixed feed. For women with a suppressed viral load, there's very little data. And as I mentioned earlier, it's essential if you're going to breastfeed beyond 6 months. And it may not really be higher risk in the second 6-month period. But I do take pause in early infancy. And the reason why I do is because we know that infants have increased intestinal permeability. We also know that there's high endocytic capacity in a newborn infant's gut, meaning that not only are they absorbing the good things, the antibodies from the breast milk, but potentially also virus. So if I can avoid mixed feeding very early, I'm more comfortable with it in a more mature infant. So how do you counsel and support parents? We could talk about this for hours, but we'll talk about it together for 20 minutes. The biggest point is be non-judgmental. Understand the woman and her family's motivations. Make sure she understands the benefits to the mother and baby of each choice. Understand if she has a fear of violence, and make sure that you're dealing with that issue as well. If there's non-disclosure to the family and partner, can you do that safely? Or do you need to help protect a secret for safety? Make sure that people understand how to get formula if that's their choice, and support and reduce risk of whichever choice they pick. Judy already showed a picture of this wonderful woman, Sierra C.C. Coven. She was in the bottom corner of the Well Project slide. And I just like to read her words, which were on Judy's slide, but which she didn't read. Cece says, "It's very important that we're given a choice, not given a choice. Like, I just need you to support what my decision is. It's not my provider's place to tell me what to do with my life or my babies. I just need you to leave the space open for discussion and choice." And if Judy didn't emphasize enough, you can take out your phone now. Here are the phone numbers. And I will end there. Thank you all.
Wow, those were really wonderful. Maybe I'm being very nerdy, but I'm having a great time up here. I hope other people are enjoying. So now we're going to switch a little bit. We're going to have a discussion with the patient perspective, we have Barbara here who's lending us her wonderful expertise. We established earlier that she has 10 years of breastfeeding, which many of us here probably are very impressed by. And so thank you, Barbara, for being here to lend your expertise and talk about your experience. And she's being interviewed by Nika Seidman, who's an associate professor of OB-GYN here at UCSF, practicing at SF General, and her clinical work and research focus on expanding perinatal services to reach patients facing significant barriers to care. So I'm going to turn it over to them. I will keep you to time as much as possible, but still give you the 20 minutes because we're excited to hear this conversation. So our Q&A will be cut a little bit short to 10 minutes, but hopefully that's okay.
Thank you so much, Lauren. Most importantly, Barbara, thank you so much for joining us today. You are really the expert on this panel, and I think we are so privileged to learn from you. Just a couple of reminders. If I ask any questions or the audience asks any questions that you don't want to answer, just say pass and we'll skip it. And yeah, thank you in advance for your wisdom.
And thank you for having me.
So Barbara, I wonder if we could start by your just sharing a little bit about yourself with this audience of clinicians and researchers and yeah.
Hi everyone, my name is Barbara. I'm Ugandan, and I thank God for the opportunity I've been given to share my story and my experience with breastfeeding with HIV. My first experience is with my 10-year-old, who is now 10 years old. When I started, I was at a viral load of 250. And when I went to my country in the clinic where I was going, they gave me the options, because at the time I wasn't on the ART. That's what it's called, right? Yeah. And they gave me options. They told me, right now we have something where you can breastfeed your child, or with conclusive breastfeeding, not giving anything, or you can decide to put your baby on formula. But coming from the background where I am from my country, Africa, it's there's a lot of stigma to like Judy, Dr. Judy said, someone can even they wouldn't want you to touch their children or to be around them if they know your status. So people are so protective of their status, and people live in fear, and people live in a lot of secretive life because of their HIV status. So with my son, since we are here to talk about breastfeeding, with my son, I must say it wasn't pretty much easy to begin with. The counseling is totally different from here, but at least they did give me options, so I had to choose, and I chose to breastfeed my son. And I had to make sure that my viral load, because at that time when I was pregnant, it was detectable. And what I listened to and what I learned is, as long as I keep my viral load undetectable, then I can breastfeed my child when he's born. So I had to take care of myself as a person, because I knew I had a life growing inside of me who did not choose to be here, but I chose to bring him here. So I have to take care of him. So I had to make sure I did not miss my doses at any time, even when I could forget to breathe, but not to take my medication. Because I knew my child depended on that, on whatever decision I decide to make. At that time, I could drink alcohol once in a while, like on parties, but I had to stop completely. I had to choose what I eat very carefully. I had to make sure I discuss everything that I'm going through with my team, the counselors that we had in Uganda. And to be honest, it was successful. I had my child. The first week, or I must say the first days weren't easy after he was born, because I had him through C-section. Since they told me the risks are low, I chose C-section. And the first days weren't easy, because I had to make sure that my nipples weren't bruised while my baby was latching, because they explained everything to me. Your baby has to be having no sores. You have to check his mouth every day before you breastfeed him. You have to check your nipples to make sure they are healthy. So I had to follow all these things. And when the baby just came out, I couldn't get breast milk so quickly, and I had to be very careful with that. So even when you cannot eat, you have to eat. Even when you don't feel appetite, you have to, because you have to get the breast milk. But eventually the breast milk came, and they told me that I could breastfeed until 1 year, But I chose 6 months because at 6 months, my baby had to start eating. And I didn't want to have that mixed feeding with my baby and then putting the risk in between. So when I came here in 2018, and I met a wonderful man over there. My partner is HIV negative, and we have a son who is now 3 years old. So I was living in LA, and when I went to LA, I made sure the moment I found out I was pregnant, I had to go get care. I discussed my pills with my doctor, the doctor I found at that time, because I was going at AHF, and then they referred me to a bigger hospital that can take care of pregnant women. When I went there, the doctor discussed the pills that I'm supposed to take, and I chose myself a pill that I was comfortable with, that was good. And so we started the journey. But my challenge was the big question every woman that can ask is, am I able to breastfeed my child? But that wasn't being discussed during my sessions when I was seeing the doctors. So I was patient, I waited. But every time I would go, I would see a different doctor, but I would ask that question. Either the doctor that I'm seeing doesn't have the right answers, or they'll tell me they are gonna ask and get back to me. But I wasn't getting those answers, but it was the big question that I'm waiting because it was so important to me as a mother and in my community, because I was living in a house where we were sharing with other Ugandans. And in our community, just like I told you, the stigma back home, it doesn't, when someone gets on the plane, the stigma doesn't stop at the airport, they come with it. It's not that they say, oh, I left the stigma in Uganda, so we're in America, and yeah, they do come with it. So I had to be very extra careful. And then I had a lot of questions in my head. So am I going to breastfeed? What if people know? Then they will stop eating from my cup. They'll start, because it is there in Uganda, in some families where they know you're HIV, and they'll give you a separate plate and a separate cup and a separate fork where they don't want to touch anything you've touched. It's still going on there. Not everywhere, but in some families it's there. So I didn't want to live like that. And that's the question I was waiting for the entire time. Every time I go back to my appointment, my partner would ask me, did you ask them if you can breastfeed? And then I said, I did, but they don't have the right answers. Until the doctor, because every time I would go there, I would maybe seen by student doctors and then they told me, oh, maybe then you have to discuss that with your pediatrician, but then the baby's still not here, but I was waiting for that big question. Believe me, for mothers who are here, you know how it feels when your baby is latching or is breastfeeding, the connection, the way they look at you, the way it feels like there's a communication going on between mother and child when you're breastfeeding. So it's very, very important. It was very important to me. I don't know about others, but me as a person, it was very important. That's why it's the very question. Every time I would go, it's the question I would ask, will I be able to breastfeed my child? And they didn't have the right answers. So this day, I go and I ask. So I was like, I'm not leaving until I get someone to tell me if I'm going to be able to breastfeed, because I was the months were gone already, about almost 6 or 5 months gone, and I needed to know. So the doctor came, and she told me, oh, they've been telling me that you want to know if you can breastfeed or not, but here in America, we don't do that. It's done back in Africa where people don't have enough food, enough money to buy formula to feed their babies. So I was like, I told her, you're talking to someone who has, by that time my son was about 7 or 6 years old, a 6-year-old whom I breastfed, he's HIV-free, and now you're telling me that I can't. Yes, in America, if you try to do it, they'll put you in prison. So I couldn't contain myself, I cried. I thought about all these things. So how am I going to get a new apartment? Am I going to move? All these questions were, but at the end of the day, I thought about my well-being as a person and my child, because I had to stay away from anything that can bring me stress to put my viral load down, because I knew the goal is to have an undetectable viral load, and I had to keep that. No matter what I'm going through, no matter what life throws at me, I had to make sure my baby comes out safe. So, thank God, we moved. We came to San Francisco. And even referring me to UCSF, they didn't give me a particular place to go to, or it was during COVID, hospitals were closed. I made calls, I called here, nobody had answers to help me. And at this time I was 7.5 months pregnant or something. So I was in panic. I don't have a hospital. Am I going to go to emergency room and give birth from there? And then one time I was like, you know what? I told my boyfriend to drive me and brought me to Penesus, actually, where your office is. There's a building where we went to up there, and I just walked in. This was during COVID. I told them, I'm pregnant, I'm HIV, and I don't have a doctor right now. I need help. Then the woman I found told me, no, you can't be here. You have to go, you might be in the wrong place, and then this and this. Because of the COVID, it was so bad during 2020, you know how it was. So I go back home still with no answers. And then I had to call my hospital again, and I asked for the doctor who referred me. That was when until I got help. And when I got help, I came to UCSF. Oh, I got amazing doctors. The first doctor that I found, she discussed what I wanted to hear. She told me about breastfeeding, but she told me that I don't know much about breastfeeding because that is not my area, but I know someone who can talk to you about breastfeeding. And she introduced me to Dr. Nika. My first approach with Dr. Nika, it was so warm that I felt a friend. The first approach she gave me, I felt a friend, and I felt safe. I was like, ooh. And then even the way she explained to me about breastfeeding and the options, I knew I was in the right place, and I was so glad that I had moved. And she listened to me to know how important it was for me to breastfeed, and she gave me that feeling that we can work with what you want. So she did not give me a choice, but she gave me options. And that's what they gave me back in Uganda. But here, when I was in LA, they didn't give me options. They gave me choices. You breastfeed, you go to prison. That was the choice. So either you decide to breastfeed by force and go to prison, or you just give your baby formula. So it was a long journey, but it was worth it. Because I was in the middle and I had wings, people holding me from all directions. My partner was supportive. I had a very good team of doctors. And then the infectious disease doctors, my Dr. Ted, Kyle's Dr. Ted, and then the hematologist. That whole team was amazing. So it was a bit of a journey, but very many appointments, very many blood work, but it was worth it because at least I knew that my son is going to be breastfed and he's going to come out HIV-free. 20 minutes?
Wow, Barbara, I am floored. I think we need to stop, pause. Thank you so much for sharing your incredible story. And I just have to say, on top of everything else, I had forgotten about COVID. And so navigating our healthcare system in the setting of COVID from a different city, you are incredible on so many levels, including that. And you have taught me so much over time. Barbara, I was wondering, I had a couple of follow-up questions, which I was wondering I could ask, and then we'll open it up to the audience. But I think the two pieces I wanted to ask you about were, first of all, you had a complicated birth, and you were readmitted to the hospital with preeclampsia with severe features. And so lots of challenges also to breastfeeding. How did you navigate that? How were you able to continue to breastfeeding? What challenges did you face? And what things supported your ability to continue to breastfeed?
First of all, what supported me was my child first. Because I knew regardless of what I'm going through, I have to be strong for this small person who doesn't know what is going on around me. And I would ask myself questions. If I collapse or if I fail to do the right thing that I'm supposed to do, protect my child, what kind of answers will I have if my viral load goes down and then I infect my child and then he did not choose that? And then those are the things that motivated me to keep going on, because I had a child who needed my support and a team that was supporting me in everything, who would listen to me, who would consider me as a friend and not as a patient.
The other question is that some of the speakers have highlighted some of the challenges, especially in the longer postpartum period, how many people have challenges, I'll just disclose myself included, taking medicines after birth when you are managing so many things. And knowing you've juggled so many things at the same time. I'm curious about how we as providers can make a safe space to disclose some of those challenges in the postpartum period, both so we can get a sense of if someone isn't able to take their medicines, or advice to patients about how, and other people living with HIV, how are you able to keep taking your medicines every day with so much going on in the postpartum period, being up all night, feeding your baby, working, all of those things?
I chose myself a time where I know I cannot forget it's bedtime usually. And I chose the same time that I give my son the it's called Nevirapine? The Nevirapine and my own medication. I chose a time that we can take it both at the same time so that I don't forget that I give my son and then I give myself. So during bedtime, it's when you're done with almost everything, the baby's ready to go to sleep, you're ready to go to sleep, and then I will take my medication. And like I said, I go back to my first reason why I was strong for my child. It was for my child. I would not forget, like I said, I would forget to breathe, but not to take my medication because I wouldn't want my son to go through that.
Thank you. So I think we're going to transition, Barbara, thank you again so much, to questions from the audience for anybody on the panel.
Hi, everybody. I have a quick and easy question for you, Dr. Levison. In your presentation, you presented some beautiful artwork. I may have missed it. Did you say whose artwork or who organized that for those middle and high school students?
Yeah, there's a particular community organizer who every year approaches local art teachers and gets these kids to produce some amazing work, and then they have a competition with an amazing celebration at the end for the top 20 or something like that, and they exhibit it it's outside of a community center, a multi-service center, and it's out there for a month, so people driving by can see. They then, it's a nonprofit that then has like sort of copyright rights or whatever. I mean, I go to them when I say, hey, I want, if I want to, and they have said, we own it now. The students have given it to us. And the students have agreed to let them use it however. And so then I'm allowed to use the art too. We've had calendars made out of some of it. And if you want to be connected with the organizer, I'm happy to do that. He just actually, I'm going to see him tomorrow. And I haven't seen him since he presented, apparently in November, he presented at the American Public Health Association, his project. So I'm dying to hear from him exactly somehow he's getting some greater recognition, which I'm thrilled about. And his idea, by the way, I mean, his goal was to reach students before they were sexually active, and therefore the focus on middle school. And so it meant that they had to research what HIV is and how you get it, and then I was, and I've just been very impressed that, they really had to think about it. This year, the one thing I'm going to talk to him about is this year, the selection, there was a lot more on abstinence. There were posters with abstinence, which is Texas. And I was a little disappointed about that. So somehow I think I had the feeling the teachers were sort of pushing that. And the other was there were a lot more with needles. And in the South, I mean, IV drug use is a rare. In 20 years, I think I've had one person who was pregnant who had gotten HIV through IV drug use, but otherwise, that's not the mode of transmission. And so I'm going to talk to him and say, you've got to correct some of these things. Explain it's not just abstinence and not using needles. You missed something there. So I'm happy to share that with you.
Dr. Short?
Yeah. Oh, sorry.
I guess it's more of a comment than a question. And, the fact that I get to work with both you guys every day and most people on the panel is wonderful. But, as an adult ID provider, one of the things I had to learn early on, and Judy and I sat in many meetings, which is how I actually met Judy, learning how to talk to patients about breastfeeding. And, I did exactly what you did. I'd walk in and say, you can't breastfeed, right? So the question or comment is, how do you get that? Because this is wonderful, and you're preaching here to the choir. How do we get that message to everyone that was not too far from here at the Ryan White Clinical Conference, who are going to be the first face to the patient who says you can't do that? It's something I've struggled with my whole career. I talk to individuals about pregnancy, but I'm unique in my clinic. Everyone else does not even address it. So it's something we all need to think about, because that message gets out there to the HIV community of providers, and we need to address that before any of this wonderful stuff can happen. That's it.
So I think I have two answers to how I ask people to address it. The first is to just ask women, how do you plan to feed your baby? And to listen to their answer. But then to very specifically ask about breastfeeding. What do you understand about breastfeeding? Do you plan to breastfeed? I actually had a woman in clinic last week who had a false positive HIV test during delivery. And so her baby was put on triple therapy. She still had her confirmatory test pending when she came to me. And I said, how are you feeding your baby? And she said, I'm using the formula they gave me at the hospital. And then I said, is your baby getting anything else? And she said, oh yes, I'm breastfeeding. And I realized nobody had talked to her about feeding. And I called the hospital 3 times to get the confirmatory test result, and then finally said, you sent her home mixed feeding, and you're gonna get sued if, and then they found it, and they faxed it to me, and she was negative, and I was thrilled that she was breastfeeding, but just making sure that you're comprehensive and non-judgmental.
And I think just about how do we spread the word, I think that is just such a good question. We've had some meetings from the perinatal panel with HRSA, and I still don't understand all the things that they do, but they have connections with, like WIC, the Women, Infant, and Child Supplemental Food Program, and things like that. And I'm kind of relying on them, and the example I gave you of where a local WIC just said, we're not doing anything to support this till we hear from CDC. I immediately wrote to somebody at HRSA, hey, wait a minute, you haven't reached them. And so I think we just, wherever we run into those things, I think we need to just follow it up the chain and educate people along the way. But yeah, I think it's a great question, and if anyone has ideas about the most effective way to reach providers, I mean, we see it just on so many levels, not even just breastfeeding, but just HIV testing and things like that. How do you reach the doctors in the community? And if anyone has an answer to it, boy, let me know.
And a lot of that for us too is when we see somebody who doesn't have the full information, we offer to give a talk to that whole hospital system. So that's a lot of the legwork that just has to happen.
Go ahead. One question that I had as I was listening to this, which was very, very interesting and very helpful for me, was whether there had been any communication or partnership with doulas, which are oftentimes a source of support and advice for women during pregnancy, but also afterwards. Are there any doula organizations that have worked with you all, to kind of make sure that your messages align, or has there been any communication with local or national doula organizations?
I don't know about nationally. I had the privilege of speaking in Detroit to the Black Women's Breastfeeding Association, and there were lots of doulas there and several different doula organizations. So it seems to have a huge presence in Michigan. We don't see it as much in Philly. Most of our moms just don't have access to doulas. So I don't know if there's a national network that would be good to reach, but I think it's happening here and there, but not systematically.
Same. Hi. First off, thank you all so much for being here and sharing your expertise, especially Barbara. Thank you all. But I had two questions, which you can choose to answer one or the other. But one was, I saw Dr. Levison, you mentioned flash heating of breast milk. So I'm very curious, can you just pop breast milk in the microwave? And is there any downside of doing that?
So, I mean, the way it's been studied, as I understand it, is pumping breast milk and putting it in a water bath that reaches boiling, and once it reaches boiling, you take it off the heat and let it reach room temperature. And it has been documented to get rid of HIV and without destroying a lot of nutrients and things like that. And there are, I mean, if you want, you can email me and I can get you the reference that describes the process where it's been tried.
Very interesting, thank you. And my other question was, is there anything known about, is there a biological or metabolic basis for why it's so hard to maintain a suppressed viral load during pregnancy and after? Or is it thought that it's just the chaos and everything that comes with having a kid, it's hard to take the pills every day?
Yeah, I think it's more of an adherence concern in general, yeah.
Okay, thank you.
I was just going to answer about the doula question. So I work with Judy in Houston, and we have a pilot with March of Dimes right now for a doula program. We also have a bunch of community-based home visit programs and things in the pregnancy and postpartum period. The thing we're kind of running into is the HIPAA and privacy concerns and how to make sure that, those programs, whether it's doula or community home-based services, are integrated with the medical team. I had one program that was great, and they were going to do multiple home visits, and we were like, this will be amazing for support and for retention and care and things in HIV primary care after delivery. But they were like, well, we can't know any medical history about the patient, was how it was set up, which for me, I was like, I don't know that I feel comfortable, if there's someone that's going to visit a patient, that's such an opportunity to ask about, to troubleshoot taking medications or to troubleshoot breastfeeding things. And so that's where I'm getting stuck in implementing more of a doula program. So that's where I am right now. Thanks, everyone. I have one final question for the panel, and then I think we'll wrap up. And definitely interested in your perspective, especially Barbara, on this. But my understanding is that a lot of these guidelines were really, part of the reason they were updated is because there was heavy advocacy and some specific qualitative research that kind of pushed the needle on this. And you both had, in the two talks, you had sort of mentioned the need for specific research. And I'm wondering specifically about qualitative research opportunities to support these other ideas. I'm interested from all of you, but anyone who wants to answer.
Yeah, absolutely. And I think that there is now more and more respect for qualitative research, and as often to help identify what are the challenges for the doctors, for the women, and then even using that as a launching off point for doing more quantitative studies. So absolutely.
And I think one of the big gaps is implementation and just understanding how different things are in different settings, and how do you implement a guideline such as the one that we have, where there's a lot of need for teamwork and the teams look different everywhere. A lot of need for counseling, but people's understanding is often incomplete. How do you really implement it in a way that makes things safe across all of these contexts that we have in the United States? So that I think is the holy grail of where we are now.
And I think one other thing is even that it seems like the word has gotten out to certain providers, and some have interpreted the new guidelines as, oh, you have HIV and you want to breastfeed? No problem. And end of discussion. It was like, no. What's her viral load? What's it been? You know, and so that that we also have to be careful that it not get that the policies get clearly communicated.
And I guess the other piece of that, which I would love Barbara's take on, is we want to make things normal in breastfeeding. And then we say, but get your viral load checked every month and bring your infant to me every month. And we're making it really not normal in trying to make it both normal and safe. And so how did you feel with the increased medical follow-up requirements that you had to breastfeed safely? And where do you think we can find the balance between making things normal and making things careful and safe?
Thank you for that question. To me, as a person, the fact that my doctors were explaining to me well of the benefits of what I was doing, I was holding on to that, knowing that the benefit is for my own good and my child. Regardless of the appointments, there were so many, but if you explain to the patients very well the benefits and where it's going to help them, I think it's good enough.
And Barbara, I hope in your next pregnancy we can do fewer visits. I did want to add really quickly from the San Francisco perspective, and then we'll end. We work really closely with doulas. We regularly sign releases of information with specific doulas to share health information, and that has worked incredibly well. The challenge for us is funding of doulas and access to doulas. We have free doula services for people who live in a certain county, and unfortunately Barbara lived in a different county and so wasn't eligible for those services. I did want to give a shout out to the state of California, which is now using Medi-Cal funding to support doulas, and so doulas will be much more accessible around this state, which is hugely, hugely important. And then I think the one final thought I had from Dr. Short about how to get out information about breastfeeding to these other organizations is to ask doulas to be on the stage, ask lactation specialists to be on the stage, ask midwives to be on the stage, because I'll just be very transparent. As an OBGYN resident, I had terrible training in breastfeeding support. And I think we really have to recognize who are the experts here and ask them to present and teach us, because we have so much to learn. So, thank you all so much. Have a great break. We'll see you at 10:15.